Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Thank you all for your continued listening of Behind the Knife. While many long-term listeners of BTK have used our podcast and resources while in medical school, we now provide resources tailored to medical student general surgery curriculum. Over the past 10 years of BTK and in our day jobs, we have dialed in the specifics of what medical students need to dominate their surgery rotation. It contains about everything you need to include review text, video, audio segments, pictures, reviewing over about 17 disciplines that you encounter during your time of service. Enjoy the series and dominate the day.
Hi, everyone. Welcome to another discussion with the University of Wisconsin Endocrine Surgery team. And today we're going to talk about what is new in the 2025 American Thyroid Association guidelines. So today we have myself, Amanda Doubleday. I am a fellowship-trained endocrine surgeon affiliated with UW Health, practicing both in Waukesha and Madison, Wisconsin. We have Dr. Alex Chiu, also a fellowship-trained endocrine surgeon at UW Health, practicing full-time in Madison, Wisconsin. Alex, thanks for being here.
Thanks for having me.
Dr. Simon Holoubek, also a fellowship-trained endocrine surgeon affiliated with UW Health, practicing in both Northern Illinois and Madison, Wisconsin. Simon, thanks for being here.
Thanks, Amanda.
And finally, for our senior expert surgeon, Dr. Rebecca Sipple. She's a professor of surgery and division chief of endocrine surgery at the University of Wisconsin-Madison. She's our most recent past president of the American Association of Endocrine Surgeons. She's an internationally recognized leader in the field of endocrine surgery with over 250 publications. So thank you so much, Dr. Sipple, for being here.
Always happy to be here to support.
Okay, so I'm going to jump into it. So we have no disclosures related to this topic. And today we're going to focus on the clinical implications from the updates from the paper titled 2025 American Thyroid Association Management Guidelines for Adult Patients with Differentiated Thyroid Cancer. This was published in Thyroid in August of 2025. So this new set of guidelines has omitted the discussion about thyroid nodules and primarily focuses on differentiated thyroid cancer, which would include papillary, follicular, and oncocytic.
Yeah, so they actually split up the guidelines into two sections this time, and from what I've heard, we should expect a new set of guidelines specifically focused on thyroid nodules coming out later this year.
Okay, great. Thanks, Alex. Good to know. So we will all be on the lookout for that. So in terms of the new 2025 guidelines, there's been some changes, and we've discussed that sort of an overlying theme seems to focus on general de-escalation of aggressive treatment, such that perhaps maybe we can accept that less surgery is appropriate. This may include active surveillance. There's kind of a new discussion about less invasive percutaneous techniques and more lobectomies versus total thyroidectomies. It does seem like there's also been a shift towards less utilization of central lymph node dissection, which actually Dr. Sipple and the UW team have already highlighted in a Hallmark paper from 2020, which they at that time concluded there was no real benefit to prophylactic central lymph node dissection in clinically node-negative papillary thyroid cancer. And now furthermore, in the 2025 guidelines, if you are to address the central neck, it would be now considered level 6 through 7. However, there's probably a lot of us that are already doing that. So then finally, de-escalation of therapy along with follow-up therapy is really discussing how to assess response to therapy early. And so this may allow us to de-escalate adjunct therapy such as radioactive iodine or even long-term surveillance. So today we're going to...
Another approach too, Amanda, just with these guidelines is I feel like it's been a little bit more patient-centered too. I think there's a lot of discussion about shared decision-making. I think they recognize that most patients with thyroid cancer do really well. And, for most patients, it's not going to limit their life, but it can have impacts on quality of life. And so really engaging the patient in the discussion about their treatment options and decision-making, and also recognizing that the burden of long-term follow-up can be significant. So recognizing recognizing how we can best support patients in the survivorship phase of their cancer treatment. So I think those are all really positive changes with these new guidelines.
Yeah, that's a great point. And I think that's something that we all learned in fellowship to kind of highlight in our discussions with patients is that shared decision-making process. So, all right, so let's present a case and then we'll talk about the different discussions and highlight some of the changes in the new guidelines. So we'll start with a 55-year-old female, fairly straightforward thyroid cancer case. She, let's say, has a 1.8 centimeter right thyroid nodule. The left lobe of the thyroid's normal. She has no clinical lymph node concern. She's euthyroid and otherwise asymptomatic. She gets a biopsy. The cytology from FNA shows Bethesda 6 confirmed papillary thyroid cancer. So she's in your office. First question is, how bad is this? And my response would be to try to answer this with a discussion about risk stratification. And we used to discuss differentiated thyroid cancer in one of 3 categories. But now with the new guidelines, it's we want to really consider this in one of 4 categories: low risk of recurrence, low intermediate, high intermediate, and high. So for Dr. Sipple, I guess I would wonder how do you interpret this, and can you explain how you would talk to your patient about these categories?
Yeah, I mean, I think for every patient, not all thyroid cancers are the same, and there's really a spectrum of disease from the really low grade, slow growing, which we probably could do nothing and they'd probably be fine, versus those that are much more aggressive. So I think there's a spectrum, and I think what we're really trying to identify for patients is where do they fall on that spectrum to know like how aggressive should we be with the treatment up front and how aggressive should we be in the follow-up. So I think, one of the nice things is I think when it's a really low grade, slow growing, we kind of all know that and recognize that we can kind of be a minimalist with treatment. And when it's really high grade and aggressive, we need to be aggressive. But I think the intermediate was kind of the area that there was a lot of variability. So in the new guidelines, they really divided it into the low intermediate and the intermediate high, with really looking at the risk of recurrence being for the low intermediate between 10 to 15 and the intermediate to high being the 15 to 30%. And I think as we think about that, that's really information we're probably going to know post-operatively, not necessarily always pre-op. But it really, I think, can probably be used to factor into the decision about when to give radioactive iodine. I think we know it shouldn't be given for the low risk, and it should probably always be given for the high risk. It's that, the intermediate group that we just don't always know. And so I think if you're going to sort of, on the decision making, those high intermediate maybe are the ones that maybe there is more of a benefit to radioactive iodine that you might want to consider giving it. But in the low intermediate, probably most of those patients aren't going to probably benefit. And so especially if their other risk stratification puts them, with a good response to therapy, they probably don't need additional treatment.
Okay, great. Yeah, and I would say for our listeners, I found this helpful that you can refer to figure 2 from the paper for a more kind of detailed definition of those categories within the different types of thyroid cancer. So yeah, I found that helpful. Great. Okay, so for surgical treatment then, we talked about, based on previous guidelines, how we would recommend a lobectomy for papillary thyroid cancer less than a centimeter. And now in 2025, we're saying that a lobectomy is actually appropriate for any PTC or papillary thyroid cancer less than 2 centimeters. So, and there's variation in that depending on your shared patient decision making, right? But so for this patient, I would offer a right lobectomy. Dr. Sipple, do you agree?
Yeah, I think absolutely. I think, this is probably the biggest shift if I think about sort of where practice was at when I started 20 years ago to where it is now. And I think early in my practice, pretty much everybody got a total thyroidectomy and radioactive iodine. And I think we have really sort of shifted away from that. So I think up to 2 centimeters, absolutely appropriate to consider a lobectomy. And I would say that many patients, even up to 4 centimeters, were considering a lobectomy. And I would say that even those greater than 4 centimeters, if they have a kind of a low grade neoplastic lesion, I think even those patients probably are okay with a lobectomy. So I think it's really the disease biology that factors into it more so than the strict size of the tumor. I would say that the decision about a lobe versus a total is a really nuanced discussion. I think one of my past fellows teased me once and said it took me longer to explain to somebody about the decision to take out a lobe than it did to do the operation. And he's probably right? Because it's a really complicated discussion. But I would say that, like, if the contralateral lobe is normal and there's no lymphadenopathy, I think a lobectomy is totally appropriate. It's going to lower the surgical risk. It's going to potentially avoid the need for lifelong thyroid hormone replacement for many of the patients. And I do think that there's this concept of people getting this asthenia post-op where they just don't feel normal on thyroid hormone replacement. And I think even if they require thyroid hormone replacement, if they have a little bit of native thyroid tissue, they just tend to feel better. So I think patients do better by just having some of that natural thyroid tissue. But I think if they're already on thyroid hormone replacement, if there's a bunch of nodules on the other side of the thyroid, if they have a history of radiation exposure, if they have a family history, those are all things that might make me favor to say maybe you're not going to be best served with a lobectomy, because we're going to still be worried about the other side and there's going to be a lot of ongoing surveillance and question marks. So I think the patients just have to understand the pros and cons of the two options and really make the best decision. I think we always say you can always take out more, but you can never take out less. So I think anytime a patient is sort of kind of not certain, I would always favor doing just a lobe, because you can always go back and take out the other side, but you can't put it back. So I think, too often people panic with the cancer diagnosis. They want to be really aggressive and then they have regret. And so I think what we want to do is avoid decision regret and sort of let people kind of do less at first. They can always choose to do more, but to not overcommit at the first operation.
Can I just say, I think one interesting point is in the previous guidelines for a lesion less than 2 centimeters, lobectomy was an acceptable option and should be considered. But on these new guidelines, they actually say you should do a lobectomy for less than 2 centimeters, kind of putting that emphasis, because I think there was a lot of data showing that people were still doing total thyroidectomies even after the last guidelines for these small thyroid cancers, when patients would probably be oncologically sufficient with just the lobe and getting more complications. This is really putting that emphasis on de-escalation and saying less than 2 centimeters, you should probably really think about a lobe unless you have other reasons to be more aggressive with a total.
Yeah, all excellent points. All right, yeah, and again, that whole shared decision making is really a factor, because you have some patients who you've proven the other side has a nodule that's benign, but they're like, nope, I want it out, or whatever is important to that patient. So, all right, so let's say we do a right thyroid lobectomy for this patient. She has no complications, in the hands of a high volume surgeon. She is euthyroid 6 weeks after surgery. And so in terms of a cancer case, typically I've been getting routine thyroglobulin levels. Preoperatively, I'll get it if I suspect a cancer, but then definitely post-op, and then continue surveillance with those thyroglobulin or TG levels, neck ultrasound, and then utilizing TSH suppression. So just kind of wanted to touch on that, because that is a change as well. The new guidelines say we can assess response to therapy within 3 months, and that a standard TG level should be done after a lobe or a total in 6 to 12 months, but that you really only need one level after a lobe if it's found to be within what you would expect. And then further TSH suppression targets now are much broader. They used to be pretty strict with certain intervals, more aggressive TSH suppression, less than 0.1 or 0.1 if 0.5 or less than 2 for low risk cancers. But now they're really saying that if it's if the recommendation for a patient who's had a low risk of recurrence, that the TSH should really be within the normal range. So Dr. Sippel, what kind of surveillance do you guys do at your practice at UW, and will that change with these new guidelines?
Yeah, so I think this is one of the changes that I was really happy to see. And it actually mirrors what we've been doing at UW for the last 10 years. I think that the previous guideline talked about sort of assessing your disease response to initial therapy at 1 year, checking the thyroglobulin and sort of reassessing sort of the disease biology. But now they're saying that really should be done at that 3-month interval. And that's what we've been doing, is checking a postoperative thyroglobulin level at 6 weeks. And I think at that early time point, you can really sort of reassess was the appropriate extent of surgery done and how did the patient respond? Because I would say there's a lot of patients who with surgery alone can get an undetectable thyroglobulin level. And so I would say as much as we focus on disease biology and the pathology report and whether or not they have high-risk features, if somebody had a larger tumor or high-risk features, but their post-op thyroglobulin is already undetectable prior to radioactive iodine, I think you could really argue what is the benefit of radioactive iodine. We've already gotten to the optimal outcome with surgery alone, and maybe some of those patients don't need it. So I think having it at that early time point really is just another piece of information to sort of put into your conversation about the pros and cons of radioactive iodine. And so I think it's a really great change. I would say that in addition to checking the thyroglobulin level at 6 weeks, we always check it again at 6 months. Just because sometimes people will have a little bit delayed clearance and it won't have fully normalized by 6 weeks. So that's why we check it again at 6 months. We do the same for a lobe. And, I think we're still trying to understand what the value of thyroglobulin levels are in thyroid lobes. I think the initial levels to make sure it's not way out of the realm of what we would expect somebody just had a lobectomy. It's going to be elevated, but I don't want it to be 100 or 200. I'd expect it to be maybe in the 10 to 15 range, kind of equivalent to somebody who has half of a thyroid. And then we check it again at 6 months just to document that it's stability. I think after that point, if it's in the normal range or what we would expect, it probably doesn't need to be checked again after that because it is going to potentially fluctuate over time. We always get a baseline ultrasound at 6 months. That's usually the first time. I think getting an ultrasound prior to 6 months, there's a lot of postoperative changes and it's not always as reliable. So I think, 6 months is the first time for the neck ultrasound. The thyroid replacement guideline changes, I think, are great. I would say I think what it's recognized is that TSH suppression probably wasn't providing a huge advantage for a lot of patients and was leading to cardiovascular risk as well as osteoporosis. And so there were probably more harm than good for a lot of those patients. And so really the new guidelines are for that most patients, they can just be maintained in the normal range. So probably the greatest benefit is for all these patients who had a lobectomy. With the previous guidelines, we had to keep their TSH low and nobody could do that after just a lobe. So what ended up happening is almost everybody who had a lobectomy ended up on full thyroid hormone replacement. And I think now with the goal being just in the normal range, hopefully a lot of those people who chose a lobectomy could avoid going on thyroid hormone replacement, which would be great. I think we're a little bit more flexible with the lobes as far as letting the TSH so they can avoid going on thyroid hormone replacement. But I think if somebody's already on thyroid hormone replacement after a total thyroidectomy, then I would say my goal is the normal range, but I would say I usually try to keep it in the 1 to 2 range just because I think people tend to feel better with the TSH at the lower end of normal. I don't think most people feel great if their TSH is 3.5 or 4. So it might be in the normal range, but I think most people just don't feel great with the TSH in that range.
I think that a TSH goal change is like a subtle but meaningful change in these guidelines that, again, I don't know what everyone quotes replacement, percentages after lobectomy, but, most of the papers say 30 to 40%. But when it comes back as a cancer, we all know, there's research to support this as well, that rate approaches at least 50%. And so, someone decided on a lobectomy and then it comes back as a cancer, whether it was expected or not. And then more often than not, it seems like you're giving them at least some thyroid hormone replacement. And, there's some impacts both like financially and just, on the patient's body, like you're mentioning with osteoporosis over time. And it's nice to be able to say, if you get a lobectomy, it really is that like 30% chance that you're going to need to be on thyroid hormone replacement. So I like that and hope to incorporate that in my practice.
Yeah, that's a great point. So that being said, then we talk about, annual ultrasounds if someone has had a total thyroidectomy, and then if someone's had a lobectomy, you want to ultrasound that contralateral side, and you can do it every 1 to 3 years. But then the new guidelines really talk about how maybe at 5 to 8 years, if they've had a great response and there's no concern for any further structural disease, that maybe we can stop following these. So that's also kind of nice to have a time point, because I've always had patients ask me, when's the end point? And it's always like, it's not, it hasn't been that clear. And I just want to point out too, at least, my practice may be a little different than someone else's at a more of a community center or an academic center where endocrinology oftentimes will get involved as well. So a lot of times I'll have a discussion with my endocrinologist about these numbers. So the surgeon may be more or less involved, just depending on your institution.
Yeah, I think you're right, though. This has been a big positive change, is sort of having an endpoint for follow-up. And I think the idea that you could stop doing ultrasounds after 5 to 8 years if they've had a good response and nothing is worrisome. And then also just stopping biochemical follow-up after, the 10 to 15 year mark. I think it's nice to know that we can never say you're cured, but we can say if you've got a good response at that time point, that the likelihood of recurrence is so low that the risks of us finding things and leading to unnecessary interventions is probably much greater than the benefits of ongoing surveillance at that point.
As a fellow of the American College of Surgeons, I can tell you, getting involved made all the difference in my career.
Yeah, Jason, same here. The connections alone have stayed with me throughout my career thus far.
Whether you're exploring a path in surgery, in training, or well into practice, the American College of Surgeons supports you at every stage. That means mentorship from practicing surgeons, opportunities to connect and lead, access to scholarships for clinical congress, the nation's largest gathering of surgeons, and a worldwide network invested in your success.
Yeah, that's right. And it's not just national. You can get involved locally right away.
With local chapters, specialty communities, and surgical interest groups, you don't have to wait, and you can get plugged in right now.
Yeah, it's not just about building your CV. It's about finding your place in surgery and staying connected throughout your career.
So head to facs.org to learn more or join the American College of Surgeons. And if you're a medical student or resident, use promo code BTK26 to waive your application fee. That's BTK26 to waive your American College of Surgeons application fee.
Okay, so I'm going to direct my next question to Dr. Chiu, because he has had some experience in our UW team now with some of the percutaneous approaches. So I'd like to get your opinion. So let's change the scenario a little bit. Let's say that we have this patient come to your office and she has a 0.7 centimeter tumor and it has been biopsied and it comes back PTC. So this would be considered a micro PTC, right? It's less than 1 centimeter. So we consider that micro. And a lot of times these tumors wouldn't get biopsied, but if it had and it came back as PTC, Dr. Chiu, what would some of the other treatment options be that we could offer this patient?
Sure. So management of these micro PTCs, I think, marks a pretty big change from the last set of guidelines. Prior guidelines would recommend a lobectomy for these small cancers that were found, but kind of staying with our theme of de-escalation of care, these current guidelines now say and offer active surveillance or percutaneous ablation for these small papillary thyroid cancers. And of course, this is all, within the realm of shared decision-making with your patient and find out what options are best for them. But getting to the specifics, according to these guidelines, so active surveillance, what they're kind of defining this as would be repeat ultrasound of this thyroid cancer every 6 months for at least the first 1 to 2 years, and then yearly afterwards. Unlike following post-treatment cancers, they don't really have enough evidence yet to say how long we need to follow these for. And I think a lot of it will depend on the specifics of your patient and their kind of goals of care. But importantly, they do put down a growth measurement of 3 millimeters as a marker of when you should really start considering intervention. And the other side of this is the introduction of percutaneous ablation for these small cancers. And for those of you who have not been exposed to percutaneous thyroid ablation, it's very similar to ablations performed in other parts of the body. The most common modality used is radiofrequency ablation, but also people are doing microwave and laser ablations to good effect. There have been a large number of studies, mostly out of Asia, that show the recurrence rates for cancer after ablation have been quite excellent. So this has been offered as an option now. As Amanda was mentioning, it's generally pretty rare a patient has a preoperative diagnosis of a micro PTC because most nodules less than 1 centimeter aren't getting biopsied. But I do think this is something interesting to keep an eye on as this general trend of de-escalation increases. There's more and more studies being conducted on active surveillance and ablation for larger cancers, and so it'll be interesting to see what the data looks like in time for the next set of guidelines if these options become expanded for larger thyroid cancers.
I think a couple things about that I just wanted to highlight was the ultrasound surveillance. I think one of the challenges is I think most radiologists can look at a thyroid nodule and measure for changes, but I would say lymph node assessment on ultrasound is highly variable. So when you're doing active surveillance, I think it is something to just sort of recognize that they should be looking at the lateral and the central neck and just making sure you're getting appropriate images and that someone knows how to look for suspicious lymph nodes, because I do think it's not just the growth of the primary, but we all have seen small thyroid cancers that can then develop nodal disease. The other thing I just wanted to ask Alex about was the ultrasound follow-up. If somebody is doing an RFA for a thyroid cancer, like how good is ultrasound surveillance of that post-RFA?
It can be tricky because it's going to look really funky afterwards. And then this may be a bit more of an issue for when you have a bigger nodule that you feel pretty good is benign and you've RFA'd. That said, a lot of folks with these micro PTCs are actually going to get total nodule disappearance after ablation, and that's kind of the ultimate effect. But that probably only happens about half the time. Otherwise, you're just going to follow these nodules. They have not set guidelines on how big or changes. I think it's just going to be within your clinical suspicion of something you or ablated is going to start growing again.
I've definitely seen some people talk at conferences where they start with like a Thyroid's 2 or 3, 3 centimeter nodule. They do an ablation, and then a subsequent ultrasound says Thyroid's 5 nodule. That maybe is shrunk in size, but because then like you go down the pathway of it, radiologist calls it as a higher Thyroid's rating, and then when you get a repeat biopsy, if that were to happen, now it's a very confusing biopsy for the cytologist to review. So you definitely kind of open up a can of worms in this situation, to where once someone's in the sort of ablation arm, like the only other option is repeat ablation or lobectomy, but the continued surveillance becomes very confusing, even for benign nodules.
Yeah, it can be a real challenge.
All right. Excellent points. Thank you, everyone. So I think we'll switch gears now at this point. I'll give the floor to Simon, Dr. Holoubek, to discuss maybe a second case that's a little higher risk.
Okay, let's see. For our next case, we're going to change this up a little bit. I'm going to direct this towards Becky Sipple. All right. Your patient is a 56-year-old male with a 4-centimeter array thyroid nodule that had a recent finding aspiration concerning for papillary thyroid cancer. The preoperative ultrasound had revealed poorly defined margins concerning for extrathyroidal extension anteriorly into the strap muscles. Preoperatively, there's a discussion about extended surgery and total thyroidectomy, is favored due to the high-risk features. Preoperative lymph node mapping reveals level 6 or, central lymph nodes on the right. Dr. Sipple, what procedure would you consent this patient for?
Yeah, so I think this is where sort of ultrasound can be really used to help risk stratify things. I would say there is a biopsy that's a PTC that is kind of just a cellular hypervascular nodule that looks well contained and has clean margins. It's probably going to be a low-grade follicular, pattern, follicular variant of papillary. And those, I think just a lobe is probably appropriate. But when they have extrathyroidal extension or poorly defined margins, or it's just sort of more infiltrative, those are tumors that are just going to be more challenging to manage in patients that are probably going to benefit from radioactive iodine. So that patient is going to benefit from a total thyroidectomy upfront. And then if there's a suspicion of lymph node disease, I don't necessarily prove it on biopsy in the central neck. If those lymph nodes look concerning in the central neck, I'm going to do a central neck dissection. I think it's especially in the setting of cancer, if they look abnormal pre-op, they're going to look abnormal post-op. So I think really looking at that central neck on ultrasound, and if there's any question, doing a central neck dissection. So while I'm not a fan of prophylactic central neck dissections with a clean ultrasound, if there's a suspicious lymph nodes in the central neck, they should get a formal central neck dissection, and that includes both levels 6 and 7. You don't ever want to just berry pick or take out a few obvious nodes. You really want to dissect out the recurrent nerve and take all the fibrofatty tissue, anterior and posterior, down to the level of the innominate on that side, and really make sure there's nothing left.
All right. So you perform a total thyroidectomy with right central neck dissection, and final pathology reveals a 4 centimeter tall cell variant of papillary thyroid cancer of the right lobe with extrathyroidal extension, and 4 of 10 lymph nodes in the right central neck are found to be positive, and the left lobe of the thyroid is normal. So, Dr. Sippel, when would you get a postoperative TSH and thyroglobulin according to these new 2025 guidelines?
So I would say that, whether it's low risk or high risk, our protocol is to get both of those at 6 weeks. And I think this is high risk pathology. So this is a patient who's going to benefit from radioactive iodine treatment. But I think that thyroglobulin level at the 6 to 8 week mark really can sort of make sure that that's the right next step. So I would expect a post-op TG in this patient to be like 0.5 or lower. Like it should be pretty low. If for some reason our threshold is if it's above 2, that's a red flag. Like a post-op thyroglobulin above 2 means we maybe didn't get it all. So prior to going down the road of radioactive iodine treatment and prep, those are patients that we pause and we get some additional imaging. We might get a neck ultrasound or potentially a CT scan. Make sure that there wasn't disease in the lateral neck that wasn't appreciated. We really want to make sure that the patient is optimally surgically debulked before you would consider radioactive iodine treatment. So I think a thyroglobulin level of 2 is sort of our threshold. So I think that that's one of the changes with the guidelines of checking that early really can help to maximize decision making and avoid treatment with radioactive iodine for disease that needed to be removed surgically. Nothing to me is more frustrating to see a post-op radioactive iodine scan with lateral neck lymph nodes that light up. Like those should have been removed surgically. We're not going to ablate them with radioactive iodine. And so I think the more we can know that before we treat, the better.
Yeah, I think that a new thyroglobulin guideline is going to be a little controversial. So I look forward to seeing what guideline adherence looks like, sort of, in that situation. So I think it's fair to say that you would refer this patient on for radioactive iodine.
Yeah, I think I would. And, like I said, as surgeons, we may not always be the ones making the final decision, but I do think our patients look to us. So we're reviewing the pathology with them. We can talk to them about their risk stratification based on the pathology. And then we have another follow-up at 6 weeks when that post-op thyroglobulin comes back so that we can incorporate that in our decision making. And we will usually give recommendations to patients. Based on this, I think you're at high risk. I would recommend the radioactive iodine, or I would not recommend it. And if they're in the intermediate, I also say that they don't have to make the decision right away. So it is okay for those patients in that intermediate who are sort of waffling on the decision. Those ones I'll say come back at 6 months. Let's get that first ultrasound. Let's make sure there's nothing that looks suspicious. Let's recheck the thyroglobulin, and then we can have the discussion. I think the decision about radioactive iodine doesn't have to be made immediately, and it's okay to wait 6 months and reassess things and make that final decision. Because I think ultimately the decision about radioactive iodine is really twofold. It's either going to be adjuvant therapy to sort of treat sort of, known residual disease or metastatic disease, or it's an ablation. And I would say that sometimes the ablation is just to destroy normal thyroid tissue, but sometimes it's to destroy microscopic lymph node disease. And so I think if the TG is still detectable after surgery, you don't really know which of those it is. But for some people, that peace of mind of getting that thyroglobulin level undetectable is worth it. And so I think it's okay to sort of have that conversation about really what are our goals of doing this treatment, and then what are the risks and benefits of it, so the patient can ultimately make the right decision for them going forward.
So for this patient specifically, after they receive their radioactive iodine, their ultrasound lymph node mapping is unremarkable. TG is 0.1, so undetectable. So I assume that would be your thyroglobulin goal for anyone after total thyroidectomy. What would be your TSH goal? And, sort of where would you go from there with this patient?
Yeah, so I would say that, in the 2015 guidelines, the goal would have been to keep the patient suppressed. I would say the new guidelines have really backed off on that, recognizing that there isn't the huge benefit. I would say that, while it is in the normal range, I would say I would typically want to keep it in the lower end of the normal range. So I would say if they have known residual disease, so if their TG is still elevated, or you have known nodal disease that hasn't been resected, then you probably do want to sort of keep it slightly suppressed. But I would say that in the absence of known disease, I think we can back off and just try to keep things at the low end of the normal range.
All right, let's end with some quick hits for everyone. The 2025 American Thyroid Association guidelines for differentiated thyroid cancer largely advocates for a de-escalation in care and an earlier assessment of response to therapy. Second, there's a strong recommendation for thyroid lobectomy for any differentiated thyroid cancer, now up to 2 centimeters, and it's open for consideration for any tumor up to 4 centimeters as long as there are no high-risk features, including lymph node metastasis, extrathyroidal extension, and all the other classic higher risk features. And then last but not least, there is no longer a recommendation to suppress the TSH in a patient who is deemed surgically complete with good oncologic response. Dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.